Good afternoon, everyone, and thanks for joining in. I'm Ellen Mason with the California Medical Association, and I will be your host for today's webinar. Today is the first webinar as part of the Data Exchange Explainer series, Overview of Data Exchange. Please submit any questions you have throughout the presentation by using the question box in the control panel, which is located on the right-hand side of your screen. We will go over questions at the end of the presentation. I'd like to introduce you to today's presenter, David Ford, CEO of CMA Physician Services and CMA Vice President of Health Information Technology. And now I will turn the presentation over to David.
All right, thank you, Ellen, and thank you to everyone who's on this webinar, spending your lunch hour with us for the kickoff of what Ellen correctly described as the Explainer series, which will be a series of 6 webinars over the next year, talking about data exchange all as part of our work to help make sure everyone knows what the requirements and expectations are under the California Data Exchange Framework. So let's jump right into it because I have kind of a long presentation today. First of all, Ellen already introduced me. I do carry 2 titles here at CMA, but just in case anyone was wondering, yes, that is also what I look like. CMA Physician Services, of which I am the Chief Executive Officer, is CMA's practice transformation subsidiary. And then I also do carry the title CMA Vice President of Health Information Technology, which I only bring that up to say I see the data exchange issue from a couple different perspectives. And one is sort of the policy-heavy perspective, but then also in CMA Physician Services where we work directly with practices on things like EHRs, HIE, electronic prescribing. So that really gives us sort of, gives me sort of both views of this issue. Big thing I want to say right up front is we want and we need your feedback. As Ellen mentioned today during the webinar, you can enter questions or comments into the chat box. We will get to as many of those questions as we can today, but even if we don't, please know that we do log all of those. We look for questions that come up frequently. Those form the basis for our frequently asked questions documents that we post on our website about the data exchange framework. You will also, after the survey, you will receive a quick post-webinar survey. It's just a handful of questions, but that's another chance for you to tell us what you're thinking about with regards to data exchange. If you prefer to email questions, if they're potentially more specific to your practice or your situation or just a little long to fit in the chat box of the webinar, dxfquestions@cmadocs.org is our dedicated data exchange framework. That's DXF, data exchange framework email inbox. That email inbox is checked every day. We do try to answer within 24 hours. So that's another place. And then finally, there will be a longer survey, so longer than the post-webinar survey, a more comprehensive survey going out soon to practices. You'll see that in your email inbox, probably within the next couple of weeks. All of that helps inform us. We think we know what is going on in practices with regard to data exchange, but obviously you know much better than we do what you're thinking about, what your concerns are, maybe what your challenges are with data exchange. And as we build a comprehensive outreach and education campaign, the more we hear from you, the more we can tailor our campaign to the issues that you're seeing in your practice. So on that note, as we mentioned, this is the first webinar in a series of 6 that we'll be doing over the next 10 months about data exchange. Now, these dates are set in stone, these topics, not as much, because as we receive input from you, if we see things that maybe we weren't expecting, maybe we didn't know were a challenge, we can build webinars to be responsive to your input. And that's part of why we want your input. So we think these will be the topics, but we always can change them if we didn't hit the mark. And if there are things you're thinking about that we didn't know we needed to build a webinar around, or do an FAQ, or do a specific resource around. So as I say, please hold these dates, but know that we may shift a little bit on what we hear from physicians who are on these webinars. So with all that background, here's just a quick look at what we're going to be talking about today. Since this is the first one in the series, we're hoping to level set a little bit. So this is really today, I'm going to kind of skip a stone across the top of the issue of data exchange to make sure that everyone sort of starts on the same level and with the same basic understanding of what we're talking about when we talk about data exchange. So I'm going to start with just a broad overview of what is data exchange? What are we talking about? What are we thinking about? I talk a little bit about some different technologies that practices might use to engage in data exchange. Because I know if I don't talk about it, it will come up in the questions. I will talk about the rules of the road. I know that practices are very familiar and think a lot about HIPAA, and then here in California, our state level CMA, those privacy rules. So we're going to do a better explanation of those in our next webinar, but I do at least want to give a lay of the land on those today. And then what all of this leads into, which is the California Data Exchange Framework, or DXF. You've probably heard a lot about that. You've seen it in the CMA publications of late. There was a big deadline that passed about 2.5 weeks ago. So we'll talk a little bit about what that is and what the expectations are, although we're going to do a deeper dive on that a little in webinar number 3. Then I do want to leave time for question and answer. That is important. Keep those questions coming in that chat box. And Ellen will be moderating Q&A when we get to that portion of the presentation. And as I mentioned, do be looking out for that post-webinar survey. That's really important and helps us tailor our presentations and make sure that we're meeting your needs. So to start out, as I mentioned, we're starting out with what is data exchange? It is a term you may have heard and may not completely know what we're talking about or what goes into data exchange. So just to make sure everybody starts on a level playing field, I wanted to make sure we answer that question right up front. Now, the reason that data exchange may be a little bit confusing or a little bit off-putting as a term is that it's not a traditional term that we have used in healthcare, especially not in healthcare policy. The term you may be more comfortable or more familiar with is health information exchange, or as it's usually referred to, HIE. So just to level set HIE, this definition on your screen comes from the ONC, which is the Federal Office of the National Coordinator for Health IT. We refer to usually as ONC. They describe HIE as a system that allows doctors, nurses, pharmacists, and other healthcare providers and patients, and this next phrase is really, really important, to appropriately access and securely share a patient's vital medical information. The access controls and the security of an HIE is what's really, really important, because of course we're dealing with protected health information in HIE, and so we can't be sending this over traditional, Hotmail, Gmail. The security levels and the access controls are not strong enough in those channels to exchange health information, so we have to set up specific channels, specific technologies, specific networks for this process, so that we can control access and so that they can be especially secure and encrypted. So you may have heard that term, health information exchange, or HIE. You may be engaged in HIE today. The reason that we don't use that term as much anymore, and we tend to use the more modern term data exchange, is because health information exchange is specific to, of course, health information. And so data exchange is similar, but it's a more inclusive term because it's inclusive of non-medical forms of data that may come from, say, a county housing department or a county public health department. They may come from a food security community-based organization, those sorts of things, which I think we all know are very important to the overall health of the patient, but at the same time are not traditionally under the umbrella of health information. So we just use data because it's a more inclusive terms. It's all kinds of data we might want to exchange or know about a patient that may go outside of traditional health information exchange. A couple more things on terminology. Data exchange or health information exchange, as I like to say, those are verbs. When we talk about data exchange or health information exchange, we're actually talking about the action of exchanging patient information, moving it from one place to another. The noun is Health Information Organization, or HIO. So the way to think about it is an HIO is an entity that facilitates HIE. And traditionally, a lot of folks will call an HIO and HIE. That's not technically correct. And so we tend to use the term HIO more often. And if you've been wondering what that is, it's the HIO is the noun. It's the entity. So for example, I just put a couple of examples of some of the most well-known HIOs here in California: Manifest MedX, Lanes down in Los Angeles County, Santa Cruz HIO, which is of course in Santa Cruz. Those are some of the HIOs here in California. There are three main types of data exchange. I sourced this from healthit.gov, which is the website of the Office of the National Coordinator for Health IT. There's a link. And yes, these slides will be sent around after the webinar if you want to follow this link and read a little bit more. I tried to sort of summarize here these three main types of data exchange that physicians might engage in. The first is directed exchange. This is probably what you think of most commonly when you think about health information exchange. It's really sending and receiving secure information point to point between two care providers to support coordination of care for a shared patient. So if you, for example, were referring your patient out to a specialist, you might send their data with them. That is directed exchange. Query-based exchange is more open-ended, and it's going on to the data sharing network and basically throwing the question out, okay, who knows something about this patient? It involves patient matching based on demographics. So for example, for me, if I were to come to your practice, you might say, okay, I have this patient named David Ford. He's 45 years old. He lives at this address in Carmichael, California, 95608. Who knows something about this patient? And various providers around California might say, oh, wait, I have a patient that matches those demographics. This might be him. That's query-based. It's often used for unplanned care where you don't have the opportunity to go and ping the patient's other providers to look for that information. And then this third one, which is less common today, but will become, I believe, much more common in the future, is consumer-mediated exchange, sometimes also called patient-mediated exchange. This is where patients hold their own health information and direct it from place to place based on who among providers they might be working with. This is definitely where the federal government was going in the information blocking rules when they created really unprecedented opportunity for patients to have access to their own health information. This is what they were thinking about, is we are going to move to a world where patients are carrying access to their health information around on their smartphones and smartwatches, and the patient themselves is directing where that information goes. That's consumer-mediated exchange. So I wanted to do just a quick, three examples of what this might look like in practice. So these are completely made up physicians and patients, but here you have it. So what would directed exchange look like in practice? So in this example, Dr. Garcia, who's an internal medicine physician, just doing a routine checkup on a patient that we've named Frankie. In this checkup, Dr. Garcia notices some irregularities and believes that Frankie needs to go see Dr. Williams, a cardiologist, using the, again, completely made up XYZ HIO. Dr. Garcia is able to push Frankie's complete medical history, labs, x-rays, medications, all of that to Dr. Williams, the cardiologist. Using this information, Dr. Williams can begin looking at Frankie's case immediately before Frankie ever walks into Dr. Williams's office. This saves both of them a lot of time and a lot of duplication, because when Frankie walks into the office, Dr. Williams already knows what medication she might be on, what her medical history is, what even things like what surgery she might have had, and et cetera, et cetera. Dr. Williams already has that longitudinal patient record. He doesn't have to spend time when Frankie walks into the office collecting all that information, and he can jump right into what their situation is with her heart and how they can work on getting her well. That is directed exchange. Dr. Garcia pushed that information directly to Dr. Williams. Common example of how query-based exchange might work. We most often see query-based exchange in the emergency room for what are probably obvious reasons. So here's just an example of how this might work. Dr. Wang, an emergency physician in a busy ER in an urban center, could be Los Angeles, San Francisco, Oakland. It all works essentially the same. In this case, Dr. Wang is called to treat a patient who is unconscious. And so the patient can't speak, can't tell Dr. Wang, here's my history, here's what medications I'm on, et cetera, et cetera. But the admissions nurse was able to find that this unconscious patient had a wallet, and from that, Dr. Wang was able to find the patient's driver's license. This gives some basic information, the patient's name, where the patient lives, age, etc. And across, in this case, the Care Quality Network, Dr. Wang is able to perform a query. Okay, who knows something about this patient? There are various different sources. That query returns information about the patient that could be vital in saving the patient's life. Things like, does this patient have medication allergies? Does this patient have a known medical history? All of that information that can help Dr. Wang in a very difficult situation dealing with a patient who can't speak for themselves. That's query-based exchange. Here's an example, consumer-mediated exchange. In this case, a made-up patient, Jennifer, is moving to a new city for work. Before leaving her old city, she downloads all of her health data onto an app on her smartphone. Then when Jennifer arrives in her new city and finds a new doctor, she directs that information to the new doctor. Again, this saves everybody time. This saves everybody a bunch of duplication, because the new doctor already has all the information they need to jump right in midstream with Jennifer. It doesn't have to go through that extensive process of collecting a health history, because the new doctor already has it. So those are the three types of exchange, and those are what they might look like in practice. So now we'll talk about data exchange technologies. There are various technologies that practices use to do data exchange. There are actually new ones that are coming online all the time. So I'm going to start with some of the more traditional technologies that you might have already encountered, you might already be working with, and then talk a little bit about what are some of the smaller ones, what are some of the newer ones that we see coming online as the technology evolves. So these are probably the ones you might have encountered and you might be more familiar with. The HIO is the one I referred to before. This is probably the most well-known type of data exchange. Again, I think there are 9 community HIOs here in California. Manifest MedX is the only one that attempts to serve all sections of the state. Lanes is one of the larger ones because it's the one that serves Los Angeles County. So those are just a couple of examples of ones you might have heard of. Some examples may even be working with. What really makes HIOs powerful is that they connect physicians and others, hospitals, health plans, community health centers, but for our purposes, we'll talk about physicians who are using multiple EHR systems. So, these HIOs will build interfaces to your practice, in most cases, almost no matter what EHR system you're working with. And as you push information across the HIO, you and the practice that you're pushing information to or receiving information from can be on different EHR systems and push and pull that information across. So they act as kind of that middle person, that sort of honest broker in the middle, taking it from one EHR, moving it to another EHR. Now, similar but a little different are the national data sharing networks: Epic Care Everywhere, Care Quality, Commonwealth, eHealth Exchange. These connect physicians and others using systems that are more based on the EHR themselves. Epic Care Everywhere, as the name would indicate, is a system that connects disparate providers who are both on Epic. Care Quality connects systems that participate in the Care Quality network. So Epic does participate in that network, as does Cerner, I think a few other EHRs. Where they're a little bit more limited is if you're on an EHR, which unfortunately many small practices are on EHRs that do not participate in the Care Quality network or eHealth Exchange or Commonwealth, and they can't get to those networks. Now, the other thing with those networks is they are national, which is good in that they can move data about patients who might be moving state to state. But you also do need to be aware of that, especially in a post-Dobbs world where we're in a blue state. You might be exchanging data with a provider who's in a red state. I don't want to go too far down that rabbit hole other than to mention that it's out there and it is an issue. There are some other technologies. One that should get more attention than it does is direct trust email. I do need to be clear in that case, I am talking about something very specific. So I am not talking about Gmail, Hotmail, Yahoo, or God forbid, an AOL email account. Direct trust email is a highly secure email system that is specifically set up for sending personal health information about patients. The reason I say direct trust email should get more attention than it does is that you may already have a direct trust email and not know it. It is built into most EHR systems. The federal NPES system has actually started publishing lists of direct trust email addresses for physicians. And so it's one of these things that a lot of physicians already have and some may not realize it. But if you can essentially just turn it on in your electronic health record, you can be using that for exchanging data today. So as I say, I wish we had more work on direct trust emails because it would be a great way to get a lot of, especially small and safety net practices going on health information exchange immediately without the need for new technology. App-based exchange or smartphone apps, again, that's going to be the growing one. That's where patient-mediated exchange comes in. There definitely are apps out there today. There are new ones coming online all the time. And as the information blocking rules really take hold, I expect to see that part of the market explode. I think patients really want it. They want that access to their own data. They want that ability to feel like they're in control of their own data. And smartphones are just going to supercharge that part of the market. Separate but a little bit, but very much related actually, is what's called a CIE or Community Information Exchange. This is specifically used for exchanging non-medical information. Some communities are setting these up to help connect people to housing, food support, even some things like education support. Things that are not quite as secure as medical information don't fall under the same rules, but as we begin to try to do more integrated, more whole person care, what we're seeing is a lot more data exchange where HIOs and community information exchanges are working together to try to move data across from one to the other, so that they can work together and you can do more whole person care. So that's a CIE, or community information exchange. And then I put this last one in here just because you'll hear this term periodically. That's called quote unquote private HIE. This is a proprietary system that's set up by a medical group, IPA, or some other closed enterprise just to exchange data within their system. So occasionally a private HIE will hold an interface out to a community HIO, but sometimes they don't. And so, so they are there. That is a form of data exchange, but it's very limited because it's only for the practices that are in that network. There's actually quite a bit of this that goes on in California because we have such an integrated healthcare system. So it's good for the practices that are in the network, not so good for the practices that aren't in the network. But you will hear that term. And I think of this slide as just before you even ask. Nothing that is up on this screen today counts as data exchange. They are terms of sharing information, but especially for the terms of the California Data Exchange Framework, which I'm going to discuss in a moment, what is up here on the screen does not count. So faxing of patient records, while that is a way that in the healthcare system we do continue to exchange patient information, it doesn't really count as quote unquote data exchange because that is not structured data, meaning that you can't go back later and search faxes of patient records using a query search to find patient information. Unsecured email, Gmail, Hotmail, etc. The only one on here I will say should not be used. So this is different from a secure email system like a direct trust email. Unsecured email can be used if a patient, for example, wants to send you an email that says, hey, can I come see you at 3 o'clock tomorrow? That's fine. But, and I know that you probably have had the experience of a patient saying, hey, doc, here's the x-ray that my doctor took of me, and I'm sending this on a Gmail to you. That is generally not advisable under patient privacy laws. So please don't do that. Or sending patient records by medical courier, calling other physicians to discuss a patient case. Again, those are ways that you are probably used to sharing information with other physicians, but there again, like faxing of records, they don't create structured data that can be searched and can be used for care coordination or for quality improvement purposes later. So none of this under the terms of the data exchange framework counts as quote unquote data exchange, even though they are ways you are probably used to sharing other information with other practices. A quick discussion of rules of the road. Now, as I mentioned, the actual legal framework of data exchange is the next webinar in our webinar series, so I'm not going to do deep dive on HIPAA and CMA today. I also will note I am not an attorney. I don't even play one on TV. So I'm not going to go too far into the details of these today. Really what I want to do for this overview is just make sure you're aware of what the laws are that do govern data exchange and that come into play when you're talking about sharing patient information with other practices and other actors in the healthcare system. So we'll start in Washington, D.C. With the federal laws. Obviously, the most well-known one is HIPAA, the Health Insurance Portability and Accountability Act. So I think every practice hopefully is more or less familiar with HIPAA. It is enforced under the HIPAA privacy and security rules. Those are federal regulations. The most important thing probably that HIPAA does is define covered entities, and which sets forth standards for those covered entities to protect the information of patients. So, and it's kind of interesting because HIPAA passed in the 90s at a time when we were just starting to implement. Really, a lot of people were just getting internet access in their homes for the first time. It was being rolled out in hospitals and schools, all these different places. And so at the time, the concern was, oh, wait a second, we're going to have health information moving around. We need to put in all these protections for it. And then, in the very waning days of President Obama's administration, the federal government also took a look at this from the other side in what was called the 21st Century Cures Act, which was one of the last, if not the last, bills that President Obama signed in office, where there was almost the opposite concern, which is, what if for proprietary reasons, actors in the healthcare system were stopping the flow of healthcare information? So the federal government defined a term that they called information blocking. This again was rolled out into a regulation, which you may have heard of as the information blocking rule. It is very important, but it came from the other direction, which was making sure that information was flowing. And probably the most well-known part of this, this rule, and the one that physicians talk about the most, is patient direct access to health information, including clinical progress notes that had never been laid out before in law or regulation. Now under federal rules, it is both. There are some exceptions to when patients have direct access to their health information. And importantly for us here in California, one of those, which is called the privacy exception, says that it is not, quote unquote, information blocking if a physician is complying with state privacy law, which is important, because California actually does have specific privacy laws that go above HIPAA. So we have the Confidentiality of Medical Information Act, which is contained in California Civil Code 56. If we have attorneys on the phone who want to look up the law and see what the rules actually are. One of the important things about CMIA is it puts some very specific controls around quote unquote sensitive information, which include things like mental health and teen reproductive health information. It puts some higher bars to gain access to those information, so more important, more stringent patient controls on those information, on that information. But I did want to point out, because CMIA is the main medical privacy law in California, that there is also over in the Health and Safety Code a specific law about patient access to health information. That actually does allow physicians to withhold some information in the interest of the patient. And in a law sponsored by the California Medical Association last year, Senate Bill 1419, that section of code was actually tightened up a little bit in response to the federal information blocking rules, because there was a concern that the information blocking rule could inadvertently force physicians to release sensitive information about their patients. For example, for teenagers to a non-custodial parent. So we tightened up that law a little bit, but it is there, and it does. So if you're looking at the federal information blocking rules, just understand how that is implemented in California is affected by the Health and Safety Code and the Civil Code. Finally, I do want to mention real quickly the California Data Exchange Framework. We will do more about this in future webinars, but it has been much in the news of late. You may, if you're on social media and you follow any of the California Health and Human Services Agency or the Center for Data Insights and Innovation under CalHHS, you may have seen some ads that look like this, where California is talking a lot about data exchange and this vision of everyone having access to their health information, physicians and other healthcare providers having access to information at the point of care. This is all being implemented under the California Data Exchange Framework. When we send out these slides, you can click on this link at the bottom of the slide to see the whole CHHS Data Exchange Framework website with all of the information about it. But I will talk just a little bit about it today in this overview. The important thing to understand about the Data Exchange Framework, or what we call the DXF, is partially what it is and what it is not. What the Data Exchange Framework is a legal framework. It will at some point include a governing entity over data exchange. It also includes a data sharing agreement that is intended to facilitate the exchange of health and human services data. Why this is important is because the state is looking at CalAIM. We're under Medi-Cal. The Medi-Cal managed care plans are going to be asked to coordinate a lot of services that we don't traditionally think of as medical, such as housing, such as food security, such as behavioral health. We needed to create a legal framework that would allow covered entities under HIPAA to exchange data with non-covered entities under HIPAA, such as community-based organizations, I mentioned before, counties, health departments, housing departments, et cetera. So that's what we're actually creating here. What this is not is a statewide health information exchange. So if any of you follow this nationally, you may know that some states, Maryland, New Mexico, have one statewide health information exchange or information organization that everyone is required to use. That is not what we did here. In fact, California law specifically prohibits that from happening. So do not think you are going to be forced to use one particular technology to participate in the DXF. So I see I'm running very long on time, so I will say two main components: a governance entity, the single data sharing agreement. Hopefully you're already familiar with the data sharing agreement, because the deadline for physicians to have signed the data sharing agreement was January 31st, about 2.5 weeks ago. Although, don't sweat too much if you haven't. There isn't actually yet an enforcement mechanism for that. But do start thinking about that data sharing agreement. It is up on an online portal that you can get through the CHHS website. As I mentioned, this webinar is part of an outreach and education campaign that is supported by a grant from the California Health and Human Services Agency to the California Medical Association. This is the first in our webinar explainer series, but number 2 will be coming up. I do not believe it is posted on the CMA events website yet, but it will be, so be watching for that soon. We've called that policy and legal environment, so we'll be doing a little bit more of a deep dive into the framework that supports data exchange, and specifically HIPAA and CMA, because I know that practices have a lot of concerns about that. We'll also talk a little bit about patient consent, because that is very important, and I know I get that question a lot. We do have an online resource center. I might be coming soon, because we're still collecting resources, developing resources. We will have a physician learning collaborative. If any of you on here are interested in being part of a collaborative and sharing information with other practices about how they do data exchange, how they view it, how they're implementing it, by all means, let us know, and we can reach out and talk to you about whether that's a way you'd like to participate. We do have a couple publications up on the website. I just before this webinar saw that our DXF page on the CMA website is live. It is ready to go, so that's a good hub for all of our resources. We do have a fact sheet and an FAQ that I just updated within the last few days to make sure all that information was current. And CMA did advocate for $50 million of state funding for technical assistance for small and safety net practices. Details to follow, except that this webinar and our outreach campaign is being funded by a small slice of that funding. Finally, I do want to mention, if you are really into health information technology issues, we would love to see you in Sacramento on May 22nd of this year for the first ever CMA Health IT conference. We have national level speakers coming to talk about the intersection of technology and practice payment reform. So that QR code on your screen, if you want to see more information, will take you to the registration page for the conference, and we hope that you will join us. So, and with that, I'll give you just a second in case you do want to snap that QR code. And then we have a little bit of time to take some questions. All right, Ellen, what do we have?
Great, thank you. We have quite a few questions for you. We will start off with this first one. Is my practice required to be able to do all 3 forms of data exchange that you described today?
No, and that's a good question, and I appreciate the questioner asking that. So we're still working out some of the details, but I believe that the query-based exchange is going to be, I think, the most important of the three. Now, an HIO, if you sign up with an HIO, will be able to support both query-based and directional exchange. Patient-mediated exchange is just kind of a different animal altogether, but the way that the statute that governs the data exchange framework is written is really about making the data available. And what that really speaks to is if another practice or a hospital, for example, contacts you and says, hey, we need this data from you, are you able to share structured data? So it's what they're really looking at is that directional exchange first, that hopefully bi-directional exchange of if another practice contacts you, can you send them data and receive data from them? And that query-based exchange, which is, for example, that ER scenario, if an HIO is looking for information saying, well, the ER has this patient who knows something about them, is your practice able to respond to that query? So those are really the two that they're looking at. And as I say, any of the existing HIOs in the marketplace should be able to support either of those. Patient-based exchange is kind of off by itself. That's just as I say, kind of a different animal.
Great, thank you. This next question. I would like to know if the data exchange program includes single provider practices at this time.
Sort of, and I'm sorry to answer the question this way. So, single provider practices were required to sign the data sharing agreement by January 31st of this year. Now, as I mentioned, please don't sweat it if you didn't. There is no enforcement mechanism at the moment. That is coming. You are required to have signed it. Now, why I say sort of is because signing the data sharing agreement is just step one of the process. So there's the data sharing agreement date, and then there's what the state is referred to as a compliance date. Now, this is the date by which you have to be engaged in data exchange. For larger practices, and by the state statute, that means practices of more than 25 physicians, that compliance date is January 31, 2024. So those larger practices have, what is it now, I guess about 11 months to be actively involved in data exchange. The smaller practices have until January 31 of 2026. So you have a little less than 3 years to be compliant. A big part of the thinking when that was done was that we want this outreach and education to happen. We also want the more hardcore technical assistance to happen to help those small practices to be ready to be compliant by January of 2026. So signing, yes. Compliance date, you have a little bit of time.
Perfect, thank you. How will the exchanges be used, if at all, for population health? Will there be special access for public health departments?
So sort of taking that second question first, I don't know that I would call it special access for public health departments, but it certainly is part of the thinking that public health departments will be involved. I think we've all learned a lot of very hard lessons about the importance of public health and public health departments over the last 3 years. And it is absolutely something that is envisioned that counties in particular have been very involved in the development of the data exchange framework so that they will have access, hopefully, to be receiving information from medical providers, but then hopefully also sending information to those those medical providers so that we can build more bidirectional, what's the term I'm looking for? Exchange between the medical world and the public health world. If you think about it from the state perspective, we're hoping for more bidirectional information moving from example, CalReady, the immunization registry, hopefully someday where down the line, the Pulse registry, like all of those things we want as part of the patient's comprehensive health record. So I don't know if that counts as special access, but they are expected to be involved. They are expected, it is expected that they will have access and that they will be actively engaged in exchange. The state is working directly with the California State Association of Counties to try to make sure that all works from the county perspective. So actually, to me, it's one of the very exciting parts of this. As I say, it's something we learned a lot of lessons about over the last 3 years about how this works and then sometimes doesn't work, so that we can incorporate information from the counties much better.
Thank you. How are patients prevented from omitting information during a patient-driven exchange?
The shortest way to answer that question is that they aren't. As long as the technology allows them to hold some information, they can, and legally under both federal and California law, that is their right. Now, I know that can be sometimes frustrating from a physician perspective, where that sometimes really crucial information that would help you treat a patient, that patient withholds, doesn't tell you, is embarrassed to tell you for all those reasons. But that is still the patient's right. And the hope is that you can build trust with your patients where they feel comfortable sharing that information. But to the questioner's actual question, yes, that is still the patient's right to withhold information or omit information. Next question.
Is there a timeline?
Oh, I'm sorry.
Is there a timeline for compliance for FQHCs?
So this is actually an interesting question, because on the surface, my answer would be yes. The FQHCs should have signed by January 31st, and because most FQHCs, the large organizations, are going to be more than, actually clinics fall under a different standard, which is the clinics that are in the 2026 cohort by the law are ones with fewer than 10 providers. So that's a very small clinic to be fewer than 10 providers. Now, the reason I say it's an interesting question, the state is planning to release a clarifying regulation at some point in the spring, because the statute says that the required signers of the data sharing agreement are, quote, physician organizations and medical groups. And so there is a little bit of murkiness about whether that includes federally qualified health centers. So I would anticipate that when the state releases the clarifying regulation on that they will opine that federally qualified health centers do count as physician organizations. But I will say at the moment it is unfortunately a little bit murky, and I hear some conflicting theories about it. So if I were in an FQHC, I would assume that you are in the January 2024 cohort for compliance, because I expect that's where it will come down when the regulation comes out. But just know that's been a sort of a little bit of a weird conversation point in California right now. Next question.
Thank you. Next question. We have direct-based trust emails through our EHR. Will that satisfy the requirement needed for data exchange, or is it mandatory to connect to HIO?
So I'm going to take that question a little bit in reverse order. It is not mandatory to connect to an HIO. That is a central component of the law, and that's really, really important. So for direct trust email, I guess here's the way I would think of it. What the state rules say is they followed almost exactly to the letter the federal information blocking rules, which is the data elements that have to be exchanged through October 6th of last year, as to mirror the federal information blocking rules, was what's called USCDI version 2, and that was a discrete set of data. From October 6th of last year forward, they say, quote, all EHI held by the practice. So it a little bit depends on how the state chooses to interpret all EHI, because the federal government has not clarified yet what exactly they mean by all EHI. But the hope is, I guess I would say my hope is that the answer to that question would be yes. And that as long as you can exchange all the data elements that are required under the rules using a direct trust email, then yes, direct trust would qualify. But the state's rules are not based around any particular technology, as long as you can prove to the state that yes, I can exchange all of the data elements required under the rules. I really am sorry that so many of my answers on this are so murky. I actually feel a bit like an attorney right now, because I'm told that attorneys are trained to respond to every question with "it depends," and there are so many things that are still being worked out in this situation that I'm trying to give you sort of what the thinking is and the thought process and the context of these conversations, because the rules are still a little bit unfolding, as I'm sure you can tell. So, with that caveat, Ellen, what's the next question?
Next question. I came to know of the data exchange recently. You mentioned about the deadline that has passed. We did not have any info about what this deadline was and what we missed. Can you summarize or point us on what the requirements are?
Sure. The requirement that passed on January 31st was the requirement to sign the state data sharing agreement. So signing the data sharing agreement basically is an agreement that says, yes, we will play by the rules, we will work with others, we will exchange data with anyone else who has signed the data sharing agreement. So it doesn't really, it doesn't lock you into any one particular technology. And actually, one thing CMA has been sort of pleased about is that the data sharing agreement doesn't actually contain a whole lot of requirements that physicians were not theoretically already required to comply with under the federal information blocking rules. So basically the data sharing agreement says, yes, you will comply with the information blocking rules, you will participate with other providers, and you will exchange data with anyone who is also a signer of the agreement. Now, I do want to say that I want to reiterate there is no penalty for not having signed. So I don't want anyone losing sleep being worried about, oh, I didn't even know there was a deadline. Everyone knows that, but a lot of people who didn't sign just didn't know they were supposed to have done so. And so, but it is something you should be looking at. And in fact, Ellen, I'm going to hope I'm going to do this right. Maybe you can help me if I didn't. I'm going to put the, no, I think this only went to organizers and panelists, but maybe you can flip this to the wider audience. It's the portal that physicians can use to sign the data sharing agreement. And of course, if you have any more questions or you need help with that, I will put that email address back up on the screen, that if you have more questions or you need some help signing with the portal. I've even done screen share with a few practices where I sat and walked them through it step by step. There is also a video, I think, that the state put up with a step-by-step on how to sign the agreement. But that's where you can look at it and get more information and look at what you're actually being asked to do under the data sharing agreement. Ellen, do we have time to take another question or two?
We do. This will be our last question. How does this affect workers' compensation? California workers' compensation routinely wants to email records.
It's actually a very good question. It has not specifically been discussed in the data exchange framework. I guess I'd put it this way. Physicians, occupational medicine physicians who do a lot of workers' comp, or OCMED or orthopedists, the folks who do a lot of workers' comp, as licensed physicians, they are required to sign the data exchange framework. Now, workers' compensation insurers are not required signatories if they are not otherwise. So to the extent, like I know some of the health plans have workers' compensation products, that's different, but by virtue of them being health plans, they will have to sign the data exchange framework. But the specific OCMED insurers, they are not required signers of the data exchange framework. But I will say there still are privacy rules that do apply under, that just generally apply to health information. So those still do apply in occupational medicine. So that they haven't come up in the data exchange framework specifically, but they are still subject to the wider laws that govern health information.
All right. Thank you, David. That is all of the time that we have for questions today. We have recorded today's webinar, and it will be available on demand on our website tomorrow with a link to download the slide deck. All of our upcoming webinars can be found on the CMA homepage or at cmadocs.org/events. Our next webinar on Thursday, February 23rd is New Nurse Practitioner Classifications, What Physicians Need to Know. Recordings of past webinars can also be found on the CMA website at cmadocs.org/webinars. Contact us at events@cmadocs.org with any questions that you have. Thank you so much.
Thank you, Ellen.